So now that we have completed our discussion on acute pericarditis, it is time to look at a few special situations of pericarditis. Let's start off by looking at pericarditis presenting to you in the emergency. I'll give you a typical case. So here we have an elderly gentleman who is a known case of lung cancer. So this patient, you already know that he has lung cancer. One fine day, he has been rushed to your emergency because he is unconscious. He is not responding, right? He is not responding. He is unconscious and he has been brought to your emergency. The first thing that you do is look for the vitals and you notice a very classical finding. You notice a triad. He is hypotensive. His blood pressure, as you can see, is 80/60. His JVP is elevated. And on auscultation of the chest, heart sounds, your S1 and S2, are not very clear. They are muffled. So you have a classical triad here of hypotension, elevated JVP, and muffled heart sounds. Can you guess what the presentation is? What has happened to him? We've already said that lung cancers can be one of the many causes for pericarditis. So since we are discussing pericarditis, please look at it as a complication of a pericardial effusion. And this is one of the classic presentations called cardiac tamponade. So those of you who have got it right, congratulations. Those of you who have not got it right, never mind. That is why we are making the whole lecture series, so that you understand more about such topics. Let's move on to why this condition occurs. Why do you have this complication in pericarditis? To understand that, you should understand what causes cardiac tamponade. Not all pericarditis really go on to cardiac tamponade. If you look at the causes of pericarditis, it involves malignancy. In India, it can also include chronic infections like tuberculosis, lymphoma, leukemias, lung cancers, rarely autoimmune conditions like lupus, sometimes even Dressler syndrome. So if you look at the major causes, they are all rapid filling effusions. The word tamponade means to compress. So cardiac tamponade occurs because of rapid filling effusions compressing and preventing the free filling of the cardiac chambers. To understand a little more of the mechanism, let us go to an illustrative diagram. To understand the pathophysiology of cardiac tamponade, I would want to remind you that we are talking about a rapidly filling pericardial effusion. So, please look at this schematic diagram here. Yes, so here we have the right atrium, the left atrium, the left ventricle, and the right ventricle. The reason why we are putting it here is also to show you that there are two inlets coming into the right atrium, one of which is your superior vena cava and the other is your inferior vena cava. So that's your superior and this is your inferior vena cava. Superior and inferior vena cava. Right? And here we have the right ventricle, here we have the left ventricle. This is the interventricular septum. So as fluid accumulates around the pericardial cavity, so as fluid accumulates around the pericardial cavity, right, within the pericardial cavity, around the myocardium, as fluid accumulates, the first thing is that the cardiac sounds are not transmitted very well. The cardiac sounds are not transmitted very well, and that leads to the first of the clinical features, that is muffled heart sounds. Muffled heart sounds. Okay, very simple reason. There is a lot of fluid collected between the heart valves which produce the heart sounds and the chest wall. So the heart sounds are muffled. The second rather easy to understand condition is that the jugular venous pressure will be elevated. So what is the jugular venous pressure? It is the same as the right atrial pressure. The SVC drains into the right atrium, and you know that the SVC continues upwards as the subclavian and jugular veins. It is the internal jugular vein in which we measure the pressure of the JV, or the jugular venous pressure. The usual JVP is between 8 to 10 centimeters of water. So when the JVP, or the jugular venous pressure, is more than 10 centimeters of water, that usually says that the JVP is elevated. Okay, the second you will see is an elevated jugular venous pressure, okay, which is more than 10 centimeters of water, right? This is the second important sign that you get. And the third important sign is that because the amount of blood that is going to flow into the right side is decreased because of the pressure, the cardiac output, that is, remember, this is the same amount of blood that is pumped into the right side, that is the lungs, and then returns into the left side. Since the venous return into the right as well as into the left is reduced, your blood pressure also is low. It is this combination of muffled heart sounds, low blood pressure, and an elevated JVP that we call Beck's triad. Beck's triad, very classical of the clinical features of cardiac tamponade. At this point, I want to take you one step further to identify some of the very specific changes in JVP and blood pressure that you see in cardiac tamponade. Okay. To look at that, let me revise a little bit of the jugular venous pressure. So all of you are quite aware of this, the P wave of the ECG. So let me just compare the ECG. This is the atrial systole. Okay, this is usually going to be followed by the QRS complex, which is what we call the ventricular systole, and then it would be followed by the T wave, right? And let me repeat that. The next we will have the P wave, we will have the PR interval, the QRS complex, and we would have the T wave. This is two ECG waves. Let me give the corresponding heart sounds. Now all of you know that there are two heart sounds, S1 and S2. S1 is formed due to the closure of the mitral and tricuspid valves. So when the mitral and tricuspid valves close, it usually means that the ventricular pressure is greater than the atrial pressure, or it is an evidence of ventricular systole. So ventricular pressure becomes more than the atria when the ventricle is contracting or during ventricular systole. If I were to tell you that which part of the ECG corresponds to the ventricular systole, you will quickly point to the QRS. So the heart sound, the first heart sound, or S1, corresponds to the QRS complex. Okay, so where you have the S1, you will have it at the QRS complex, right? So without looking at the ECG, you can say that it is probably the QRS that is happening in the patient's heart when you hear the S1. Similarly, what is the S2? It is the closure of the aortic valve. When does the aortic valve close? When the pressure in the aorta is lesser than the pressure in the ventricle. That is possible only when the ventricle is relaxing. So what is the point at which the ventricular depolarization occurs? That is the QRS. Which part of the ECG does the ventricle contract really? The ST segment. So even though there is no electrical activity, this is exactly the part where the ventricle is in systole. Following that, it is after the ventricular repolarization that occurs that the ventricle starts to relax. So ventricular repolarization starts here, ventricle starts relaxing at this point, and the pressure in the ventricle becomes less than the pressure in the aorta somewhere around here, that is the middle of the T wave. So at that point, the aortic valve closes and produces the S2. There you are. Now, you know that the S2 corresponds to the middle of the T wave. So these is two important points that I have told you, that The S1 corresponds to the QRS, the S2 corresponds to the middle of the T wave, and remember S1, S2 is the systole, S2, S1 is the diastole. Look at it carefully and you will see that the systole is only half the duration of the diastole. We will discuss all of this in greater detail later, but this is just a refreshing your basics on ECG. Now, the JVP or the jugular venous pressure waves. Okay. So, if I ask you how many waves are there in the JVP, all of you are going to tell that there are 3 waves, the A wave, the C wave, the V wave, and 2 descents, the X descent and the Y descent. Now, let me recollect these, that the A wave corresponds to atrial systole. So, where in the ECG is there atrial systole? Bang, that is the P wave. The P wave in the ECG is the atrial systole, so the A wave will pretty much correspond to the P wave in the ECG as far as time is concerned. So, what happens after the atria contracts? After the atria contracts, now the pressure in the atria is built up and you can see it in the jugular pulse. The blood is beginning to flow from atria into the ventricle throughout this, and then you can see you go into ventricular systole. As you go into ventricular systole, you know S1 or the atrioventricular valves, mitral and tricuspid, close. Even though the tricuspid valve is closed, the tricuspid valve is pushed a little upwards, or you say there is a coning of the tricuspid valve. This produces our second small wave, A wave, C wave. So, if somebody asks you what is C, C stands for coning of the tricuspid valve. That is because of ventricular systole, right? So, this is ventricular systole. So, what happens to the jugular pressure after that? The jugular pressure after that starts to fall. Starts to fall because at this point the atria is relaxing. So, remember atrial relaxation. If somebody asks you what is happening during the X descent, why is the pressure falling during the X descent? It is atrial relaxation. Atrial relaxation, right? Now, as the atria relaxes, it is quite simple to understand that blood will now start flowing into the atria and gradually the pressure starts to increase. Now, the pressure starts to increase, meaning it starts to slowly rise, and this upward movement peaks as what is called the V wave. So, what is the V wave? It is the slow venous filling. It is the slow venous filling. The max of the V wave is somewhere corresponding to after the end of the T wave. So, you have an A wave, you have a C wave, and we have a V wave. So, now what is happening? Blood is collecting inside the atria, pressure in the atria is building up, ventricular systole is over, now the aortic valve is closed, ventricular is relaxing further, and at this point the atrioventricular or mitral valve will open up. That is when the ventricular pressure is less than the atrial. During the diastole, the atrioventricular valves open up and there is a sudden flow out of blood. Okay, blood begins to flow out. Okay, why descent is because atrial decongestion into the ventricle. This is the cause of the Y descent. Why do I really want you to know this? Because there are going to be some very interesting changes. As the atria decongests, the Y descent occurs, and gradually by the end of the diastole, again the pressures will start increasing as the venous filling will start taking it upwards till we go on to the next A wave. Sorry, I'll show you that here. Till we go on to the next A wave. As the pressure increases, you will go on to the next A wave. Okay, so this is where you will get the A wave. You will have a C wave, which is due to the coning of the tricuspid, after which you will have the X descent, which is because of atrial relaxation. After the atria relaxes, there is going to be gradual filling of the atria, venous filling. That will produce the V wave, which peaks after the S2, that is in the diastole, and then when the Y descent occurs, that is because of the opening of the tricuspid valve and fluid or decongestion of the fluid into the ventricle. So this is what you normally call the ECG waves. What happens in tamponade? Okay. So let's look at cardiac tamponade. What happens in cardiac tamponade? I would want to focus only on your JVP. First things, there is going to be, it is much more difficult to decongest here because the pressure in all the four chambers are going to be elevated. Pressure in all the four chambers are going to be elevated, including the right atrium. So first, the jugular venous pressure is greater than 10 centimeters water. This is the first thing that you are going to see. The second that you are going to see is that it would look something like this, right? Your A wave and C wave. So if this is the normal A wave and C wave in a patient who is having cardiac tamponade, this is going to be the A and C. So you can pretty much compare that the A and C are both elevated. Both the A and C are elevated in cardiac tamponade. Now remember carefully what is the X descent and the Y descent. So here is the X descent, it is atrial relaxation. When the atria relaxes, okay, the sudden relaxation of the muscles will produce a sudden drop of pressure all the way down to the same as, okay, this is 0. In complete relaxation, the pressure in the atria goes down to 0. So it will be 0 here, it will be 0 here to an extent. So you can see that from a much higher baseline, there is a sudden dip. So this produces a sharp X descent. Sharp X descent is very classical. This is because of atrial relaxation. Atrial relaxation, right? Then the same thing happens. Okay, blood starts accumulating here. Only thing, the V wave is also much taller because again, the ventricle and the atria are both being pressed from outside. But when it comes to the Y descent, what is the Y descent? Y descent is because of the atrial decongestion into the ventricle. Now remember, the ventricle is also under pressure. So when the atria tries to decongest into the ventricle, okay, that dip is not very significant. Remember, X was because of atrial relaxation. Nobody is stopping the atria from relaxing. But at the same time, when the atria is trying to let blood into the ventricle, that is also being compressed by the pericardium. So that descent is not as sharp. So in the JVP of cardiac tamponade, what you will get is a sharp X descent. Why is this important? Because we want to compare this with constrictive pericarditis. In cardiac tamponade, you will have a sharp X descent, but you will have a normal Y. Remember this. Okay, a sharp X descent, but a normal Y descent. This is very important to understand the jugular venous pressure findings in cardiac tamponade. Now, I will take you one more place to try and understand the intricacies of blood pressure changes. One thing very easy for us to understand is that blood pressure falls in case of cardiac tamponade because the ventricles are not being filled very well, so the blood pressure falls. In addition to a fall in a blood pressure, there is a very interesting clinical feature which we can use to diagnose cardiac tamponade, and this is the phenomenon of Pulsus Paradoxus. So, what is this phenomenon? It happens during inspiration. So, a patient who is having cardiac tamponade and is breathing, during inspiration and expiration, there is always going to be some pressure changes. During inspiration, because our intrathoracic pressure is negative, the reason for that is pretty obvious. During inspiration, the diaphragm moves down. That would make the intrathoracic pressure negative. It will pull in more blood into the right side of the heart. So, inspiration brings in more blood into the right side of the heart. Normally, this will produce the right ventricular wall to bulge outwards. Effectively, the interventricular septum will remain where it is. However,
In case of cardiac tamponade, the right ventricle cannot move outwards. Why? Because there is a lot of fluid there, right? There is a lot of fluid. So the right ventricle is unable to move outwards. The right ventricle is being compressed by the fluid so much that the pressure in the right ventricle, especially when there is during inspiration, might actually be slightly more than the left ventricle, and whenever you are breathing in, that excess pressure will cause a movement of the interventricular septum to the left. So what do you think will happen if the interventricular septum moves to the left? Yes, that would make it difficult for the blood to fill in the left side. So, in inspiration, there is an increased right ventricular venous return, and this increase in right ventricular venous return will push the interventricular septum to left, and that will produce decreased left ventricular filling, and that will produce further fall or an exaggerated fall in blood pressure. An exaggerated fall in blood pressure. Okay, I'd correct this as exaggerated fall in blood pressure. So if somebody asks you, what is Pulsus Paradoxus? It is an exaggerated fall in blood pressure during inspiration. How much? It is said that the systolic blood pressure falls more than 10 millimeters of mercury during inspiration. The systolic blood pressure falling more than 10 millimeters of mercury during inspiration. This occurs because the right ventricle is unable to expand and accommodate the excess fluid, so it pushes the interventricular septum to the left, reducing the left ventricular filling, and that exaggerates the BP fall. So this will cause a paradoxical disappearance of the pulse in your arms in case of tamponade during inspiration. This gives its name Pulsus Paradoxus. Okay, Pulsus Paradoxus. Remember, it is a blood pressure finding. So when you're measuring the blood pressure and there is a difference of 10 millimeters between inspiration and expiration, that is what we call Pulsus Paradoxus, right? Pulsus Paradoxus is a very sensitive sign of cardiac tamponade.
Understanding the pathogenesis of cardiac tamponade will help you to understand the clinical presentation. So we know that due to the impaired filling, we have the classical clinical triad, which is called Beck's triad. This is hypotension and elevated JVP due to elevated filling pressure and muffled heart sounds. In addition, a very interesting finding that you will have is that during inspiration, there is a blood pressure drop of more than 10 millimeters as compared to expiration, and you already know that that is called Pulsus Paradoxus. So this is our clinical presentation, and we have also seen that the same reason, the same tamponade can lead to ECG findings of low voltage complexes and electrical alternance, that is an alternating positive or negative axis with each heartbeat. Okay, so you can see the axis changing or the QRS complex swinging from one to the other side with every heartbeat. That's called electrical alternance. The echocardiography is very useful both for the diagnosis as well as in the management of cardiac tamponade. In echocardiography, you can first visualize the fluid. The most sensitive parameter for cardiac tamponade is the collapse of the right ventricle. The right ventricle collapsing in diastole gives you a very sensitive indicator that your patient is in tamponade, and there will be a detailed link to a video that I would have in your show notes, which you can see as to how the right ventricular diastolic collapse appears. Once you see the right ventricular diastolic collapse, the treatment is immediate emergency pericardiocentesis. You need to put in a catheter into the pericardial cavity. This is best done in a guided manner. You can put it in a guided manner using the echocardiography so as to hit the pericardium itself and not to touch the myocardium. Of course, If the echocardiography is unavailable, very rare nowadays, you can also insert the catheter in the subcostal plane. You insert it in the subcostal plane at an angle of 45 degrees with the horizontal. You insert the catheter towards the left shoulder. As you are advancing it in the subcostal plane, in the subcostal region, you will, or the at the junction of the xiphisternum and the costal angles, you will hit the pericardial fluid. Of course, blind pericardiocentesis is rarely practiced nowadays. It is safer, much safer procedure if you can do it under echocardiographic guidance. Remember, putting in the catheter and draining out the fluid is only the emergency treatment. You need to treat the underlying cause or leave the catheter if the cause is not treatable. For example, if you're looking at disseminated lung cancers, there is high chance of recurrent pericardial tamponade. You might even have to leave the catheter there, right? So this is the presentation of cardiac tamponade as an emergency. We will look at the other special presentation of pericarditis now.